All righty. Well, welcome to the GEDC and GEDA, the GED webinar on what matters in the emergency department, addressing goals of care and meeting the CMS Age-Friendly Hospital measure in the geriatric ER. We're very grateful to be doing this in conjunction with the Institute for Healthcare Improvement and our continuous supporters and collaborators, West Health and John A. Hartford. I'm Kevin Biese. I'm an emergency medicine physician at the University of North Carolina at Chapel Hill and wear a number of hats there. Relevant to this, I'm the chair of the Geriatric ED accreditation group and the principal investigator of the education and implementation part of the Geriatric Emergency Department Collaborative. So very grateful you're here. You're going to hear from a number of us today, four to be precise, and then hopefully many of you chatting in and bringing up questions and conversation points. So I'm going to be joined today by Dr. Christina Shenvi, who is educator par excellence in emergency medicine. The rewards she's won are too numerous to count. She also is a graduate of Geriatric EM Fellowship back in the day, currently is the president of the UNCM Academy of Educators, and a real champion in understanding the essence of geriatric EM and how to educate and communicate that essence to others. And she'll be talking to us about the quality measures of CMS and why we care, because usually quality measures sound really boring, but we like these ones. Also, Dr. Sood from Northwell is going to be joining us. She is helping run or now in charge of their geriatric ED efforts. And Northwell is a large healthcare system in New York, the first healthcare system in the country that had all their emergency departments become geriatric accredited back in the day, and a tremendous leader in thinking about how to implement, quote unquote, what matters, advanced care planning in the ER by ER providers and the impact that that has. So she'll be sharing with us both the vision and the practicality of getting it done. And then Erin Malsh is Geriatric Emergency Department Director on a collaborative director, and more equally importantly, led Advocate Aurora's efforts to accredit over 20 geriatric ERs in his system, so brings a wealth of knowledge. And all of us together are going to be talking about what matters in the ER, how to get at what matters in the ER. And what matters to our patients has always mattered, but maybe in a slightly different way now because it's the centerpiece, if you will, of a new CMS measure to which we'll all be held accountable. And I never thought I'd say this about a CMS measure, but a new CMS measure for which I am grateful and excited to announce. Excitement and CMS don't usually go in the same sentence, but these days they do. And I'm excited to share about the new measure that we're going to talk about together. Please, as we go forward, put your questions in the chat. And we'll have time at the end, which means I'm going to talk less so that we can hear from you all more and hear from our awesome panel more. I'm going to talk a little bit about what geriatric ERs are because we are privileged to be doing this in collaboration with the Institute for Healthcare Improvement. So some of you may not be as familiar with our every other month webinars. So we'll give a little bit of backdrop on that, how it interdigitates and really is supported by the 4Ms framework in age-friendly hospitals, and then transition over into an overview of the CMS measure and how to think about that with Dr. Shenvi. Next slide. So what's a geriatric ER? Well, I think of it as four key components to a geriatric ER. I'll tell you what a geriatric ER usually is not. It is not a separate space where you go if you're over the age of 65. Like no one asks for a Medicare card and then you take a hard left and go to the geriatric ER in most places because most of us don't have separate ERs or the ability to build separate ERs for older adults. Many of us have separate places or spaces, and part of a geriatric ER is really thinking about what are the physical needs of older adults. If you have a lot of money and you can build a new space for older adults, fantastic. Sometimes philanthropy makes that possible. But more often, it's about light dimmers. It's about getting people out of the hallway when possible. It's about having a chair for the daughter or son or care partner. Keep them in the ER. They're your best friend. And it's about thinking about basic structural enhancements that can really make a difference. Sometimes it's just teaching your team not to shine bright fluorescent lights on people's faces all night long and expect them to sleep well and then not get delirious if they're at risk for it. So geriatric care is about structure. It's about process. It's about really picking the right populations to screen for to understand the underlying geriatric syndromes beneath the chief complaint. So a fall in myself or our other panelists is probably an isolated event. A fall in an older adult may well be part of a syndrome of geriatric falling, and you want to be looking at things like polypharmacy or frailty. And so how do you get at those in a systematic way? So it's about having systematic processes, so it's not just dependent upon the two people that are really passionate about geriatric care in your department, but expands it into the hardwire. It's about education, so everybody else becomes passionate about it as well. For that, I refer you to the GEDC website that we'll talk about with so many great resources, including Dr. Shenvi's podcast, Gemcast. If you're like me, it's hard to sit down and read. I'm always on the move. I can be on the move with Gemcast, and so many other great resources there, including CME-backed materials. And then community connection, moving the ER from becoming the front door of the hospital to a place where you don't always have to come into the hospital, but can be reconnected to community resources, both medical, consults, follow-up, physical therapy, and social, Meals on Wheels, and other reasons that we all know people come to the ER when they don't know where else to go. Next slide. And it works. The data is still growing, but the bottom line is that we know that, not surprisingly, patient experience goes up when people are in a place that's been designed, not just physically, but process-wise, education-wise, with them in mind. We know that in the right systems, the amount of admissions goes down, which is actually of increasing interest to so many of our healthcare partners right now, where most of us are in what I think of as a capacity crisis. And that's almost ubiquitously true across the country right now. So we've got to be thinking differently, and a geriatric ER gives you that opportunity to connect the patient with resources rather than admitting them. As a result, it saves Medicare a lot of money and can actually be financially beneficial to the hospital. And if you get the right services in the ER, you're less likely to have to come back to the ER. And if you get admitted from the ER because we're starting the full workup downstairs, you don't have to stay upstairs as long. And some of that full workup is around what matters or advanced care planning. And Dr. Sood will be sharing some of that, her findings at Northwell around that. So bottom line, it works. It works for the patient, most importantly, care partners, most importantly, and then also for the hospitals and the insurance companies. And the government in this case is just one big insurance company. Next slide. As a result, there's lots of geriatric ERs. This says 500. It's more than 500 now. I've given up on trying to keep count because every time we get one, it's probably about 520-ish. I'm sure I'm off by a couple. And GEDC sites are popping up all over the country and world as well. GEDC is sort of we like to think of it as the mini IHI of geriatric care, meaning it's a learning collaborative that spreads best practices freely amongst all its members so we can all learn from each other. And this webinar is an example of that. Next slide. For those of you who aren't familiar, there's 3 levels of geriatric ER accreditation: bronze, silver, gold, or 3, 2, 1. 1 is the highest. Think trauma centers, for example. And I guess I would just say that even level 3s that are meant to be obtainable by every emergency department in the country begins to till the soil to plant seeds of real transformative change in the way that care is delivered. And so all of these can be really important. Happy to go into more details, and the websites have the information as well. And we're happy to connect you with the folks to learn more about accreditation and GEDC. GEDC's the Learning Collaborative, lots of great opportunities here. Aaron will talk a little bit more about those at the end. But bottom line, if you're on this webinar, you should probably be in the GEDC, and you might want to consider becoming an accredited ER as well. GEDC is a free resource for people to share best practices. All of geriatric emergency medicine is really based on the 4, or we say 5, we snuck another one in there, M's of geriatric care: mobility, mentation, medication, and most relevant to today's webinar, what matters. We snuck in elder mistreatment just because it's so prevalent and so under-detected, and many are coming through the ER. So we don't have any magic bullet to solve it. We have some great resources and toolkits to help better detect elder mistreatment. But you'll find on the GEDC website toolkits and resources and educational materials around all 5 of these M's as you roll your programs out across your emergency departments. Next slide. And it all works as part of an age-friendly healthcare system, really the framework, the lexicon that helps so much of this work move forward. And thanks to Johnny Hartford and IHI for launching that in such a robust manner with such profound impact. Next slide. So today's conversation is really going to be around what matters as the centerpiece of the new CMS Age-Friendly Hospital measure. And I'm just going to tell a quick story about what matters in the emergency department, how I think about it. And then I'm going to turn it over to Dr. Shenvi to go more into the measure and her experience. So this is about 7 or 8 years ago. I'm working at UNC's emergency department, and I'm already like heavily involved in geriatric EM care. Like I'm supposed to be the person that knows all about geriatric EM care. And I saw this 72-year-old woman. She was pretty healthy. She looked all right. She was there with another family member, and she had abdominal pain. And I pushed on her stomach some, and it was tender, maybe in the left lower quadrant, but not very tender, not peritoneal. But like it's not too complicated. If you're over the age of something and your stomach hurts, so you're usually going to get a CAT scan in the ER if you have some sort of positive physical exam. And so I was like, "Oh yeah, ma'am, no worries. We're going to get you a CAT scan. Don't you worry. Hang out here for a while." Boom, 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 boom. So I come back like 6 hours later, 5 hours, whatever it is, and I give her my usual, "We don't have any idea what's wrong with you, but isn't that great" speech. It's so good that we didn't find anything because we look for bad things. So that means you didn't have those bad things. So why don't you go see your doctor? And she looks at me with this relief in her eyes. Will not forget the look on her face, and says, "Thank goodness. Now I know I don't have colon cancer like my sister just died from colon cancer." And I thought, no, no, we don't. Like, this is not the right test for colon cancer. I mean, you don't have huge masses in your abdomen that have metastasized. But we just went down an entire pathway, took up several hours of your time. Why? Because I didn't take one more minute at the beginning of this evaluation and say, "No, really, what are you here for? What are you worried about? What's on your mind? What do we need to make sure we know at the end of this evaluation?" So, like $5,000 and 6 hours, 7 hours, whatever later, we haven't answered the question because I never found out what it was. What matters certainly involves code status and advanced care planning, and that's critically important. But I think it really comes down to sort of taking even that extra minute and potentially saving 6 hours. Not actually advocating for longer ER visits. I would have discharged her with a colonoscopy plan at that point. Highly likely that would have been my next move because her exam wasn't that concerning. But it's about taking that one more minute, as you see with Dr. Don Milady, sitting beside the bed and asking, "What's going on? And can we make sure we ask the right questions and get you the care that's aligned with what matters to you?" So I'm really excited that CMS has made this not just like extra credit, like, "Oh, by the way, if you feel like it, you can also ask them what matters," but has begun to make it part of core competency of practicing healthcare in the United States. And so with that, I'm going to turn it over to Dr. Shenvi to talk a little bit more about the measure and the different components of it. I think you can skip this one. I mean, Dr. Shenvi will touch on the 5
Great.
components.
Well, thank you, Kevin. Thank you for that introduction. My goal now is to give you a little more of an in-depth view of what this measure involves and what you can do to meet it. And then we'll hear a story from, or the Northwell experience from Dr. Sood about how they implemented it. So these are the 5 domains of the CMS age-friendly measures, and these were approved August of this year. And the way it will work is hospitals will need to attest that they are doing them starting in 2025, and then in future years, they will be involved in part of the reimbursement decisions. So these are the 5 domains. And the very first one is eliciting patient healthcare goals. And I'll just briefly read the rest of them so that you have some awareness. Domain 2 is about responsible medication management. Domain 3, frailty, screening and intervention. Domain 4, social vulnerability. And domain 5 is having age-friendly care leadership. And I want to highlight that domain 5 because that's a necessary one for all the others. And it aligns with the geriatric ED accreditation requirements. So without domain 5, without having someone who is or a committee who is designated as the geriatric care or age-friendly care leadership champions, then none of the rest of this will be able to move forward. Next slide, Heather. So let's look at domain 1, eliciting patient healthcare goals. This focuses on making sure that 1, we are understanding what those patient healthcare goals are, and 2, involving those goals and making goal concordant decisions about care. So it's not enough to just know, oh, this patient is worried about having colon cancer, but then making sure that we're using that information in their decision making. Next slide, Heather. So this is what it actually says. This is what's required, that hospitals will attest that their hospital has a protocol in place to ensure patient goals related to healthcare are obtained and reviewed and documented in the medical record. And these should be updated before any major procedures and when there are significant changes in the clinical status. And if we look at what are those goals that should be included, health goals, treatment goals, as well as things like living wills or healthcare proxies and advanced care planning. And this applies to all patients age 65 and over. So we can't just select a subset. This needs to be all patients. It can occur in the ED. That's certainly when there may be a significant change in clinical status, or in clinic, or on admission. But it needs to be obtained, reviewed, and documented somewhere so that if this is done in clinic, then we in the ED can see it and let it help guide our decision making. And the spirit of the measure is really that goal concordant care. It's not about the letter of the law and just checking a box and saying, do you want CPR done? Well, yes, we want to know if our patients want us to attempt CPR, but it really goes beyond just documenting code status, Heather. And here, next, I want to explain how these CMS measures align with the goals and processes of geriatric ED accreditation and the age-friendly health system requirements. And the purpose here is so that you understand if you are implementing these CMS measures, how that can help you become a geriatric ED, or if you're already a geriatric ED, how that overlaps with the CMS age-friendly measures. There's not going to be a pop quiz on this at the end. This is just to give you an outline of what's involved in geriatric ED accreditation. As Dr. Biese mentioned, there are 3 levels, level 3, 2, and 1. And to become an accredited geriatric ED, you need to have some staff who are leaders, a physician and nurse champion, case manager for level 1 and 2, and you need to develop the care processes or systems to improve care. And there are kind of a menu of different care processes you can pick from, and then you choose which ones to implement based on your site, your resources, and what will have the biggest impact for you. And then there are some structures that you have to have, some resources like having canes, walkers, access to food and drink, etc. So this is big picture, what is involved in geriatric ED accreditation. Next slide, Heather. Now, on the left-hand column, I've listed the 5 CMS domains. And then in the middle, I've listed how these have overlap and intersection with the geriatric ED accreditation care processes. So we're going to focus and zoom in, next slide, on just CMS domain 1. And there are 2 geriatric ED accreditation care processes that would help intersect or help you meet domain 1 of the CMS measure, or vice versa. The geriatric ED care processes all have letters and numbers. So F3 is a care process to ensure what matters most is asked about, to identify the patient's priorities, and to incorporate their priorities into the care provided. Another one that overlaps some is having a care process for accessing palliative care consultations, where they can potentially come down and have additional, more involved discussions. So if you have this care process implemented, that will help you meet the CMS care measures or domains, domain 1. Or if your hospital is more globally implementing processes both in the ED or in the inpatient care setting, that will then help you meet the geriatric ED accreditation. Next slide, Heather. Thanks. So what does this mean for your hospital? Well, you will need to designate an age-friendly champion or an interprofessional committee. And if you're not an ED physician, nurse, etc., then make sure that you're involving the ED as you are setting up that interprofessional geriatric care leadership, because so much of those decisions are made from the ED, and you really need somebody representing the ED involved. You will need to develop a process for identifying what matters most and incorporating it meaningfully into the patient's care plan. My fear as these things roll out is that hospitals may be tempted to just have a checkbox that, yes, goals of care are documented, but it's not really involved meaningfully in the decision making. It's just, yes, we've documented their code status, which is necessary, but not sufficient to really meet the spirit of this measure, Heather. And the ED is a place where incorporating what matters most is really important, and it can lead to more patient goal congruent care. For example, if a patient says, oh, what matters to me is really getting home, I don't want to be in the hospital. Or what matters to me is, my family member really isn't safe at home. So what matters to me is making sure that they have somewhere safe to go to. That can then lead to earlier engagement with hospice or potential shorter lengths of stay. Next slide. So asking about what matters most is one of the geriatric ED accreditation care processes. So if you incorporate this into your ED care, that will allow you to more easily meet accreditation as a geriatric ED. Next slide. So as we think about what will this take as to roll out, well, you need to have a way to easily document and easily view those goals of care or what matters most. So whether that's a note template, a dot phrase, or some way that if it's documented in one ED visit, then I can go and reassess it. But really, it should be something that we're asking about at each visit, to Kevin's point earlier. And we need to think beyond just code status. Another thing that we will need in order to implement this is we need to train our physicians or our nurses or our APPs how to incorporate what matters into their discussions with the patients. And most of all, we need to make it meaningful, not just checking a box. Next slide. This is one example. This was something that Kevin and Mary Tonetti at Yale helped put together, which is a practical guide for questions that you can ask or wording to give your clinicians to ask patients. So first, letting the patients know why you're asking the questions. In our ED, we want to make sure we understand what matters to you most and make sure that the care we're giving you is right for you. So this helps frame it for the patient. And then a couple options there in the second line of assessing what are they most worried about. So what concerns you when you think about your health and being in the ED today? Or what fears or worries do you have about your health? This question, to Kevin's example, would help solicit, oh, my sister just died of colon cancer and I'm really worried I have colon cancer because I'm having some belly pain. That can really help then identify their goals. And then third, and I love this, what outcome are you most hoping for from this ED visit? This can open the box to, well, I'm really hoping to just get some antibiotics and go home. Or I'm really hoping for my mom to be admitted because she's not safe at home. So this can help align the care with what matters most to each patient. And these questions won't take a whole lot of time. And I think Dr. Sood will show us next how they can actually save time in the long run. Next slide, please. So with that, I'll turn it over to Dr. Payal Sood, who's going to walk us through the Northwell case study. Thank you.
Thank you so much, Christina and Kevin. And you both definitely spoke to a lot of things that leading up to what I'm going to talk about. You can go to the next slide. So just for everyone on the line, I know we have people from all over, may not recognize what Northwell Health is or what it consists of. So just a really brief overview. So we're located in New York. We're the largest healthcare provider in New York State. And we consist of 18 emergency departments. So you can see the breakup over there. We have one quaternary care ED, which is the site that I'm representing today. I'm going to talk a little bit about how some of these initiatives that we've talked about and our goals and visions aren't just reserved for quaternary care EDs. It's something that we've been able to achieve at our smaller EDs and are working on in our larger EDs as well. So even though it's not a one size fits all, there's a lot of different flavors to the care of older adults, which we can adapt no matter what kind of practice setting we're in. So one quaternary care ED, 5 tertiary EDs, 11 community EDs, and then 1 freestanding ED. And a few years ago now, I can't remember what year it was, it really became a system goal, really aligned with our vision to ensure that all of our emergency departments in some way, shape, or form are aligning with our mission and our vision of providing appropriate care for older adults. So overall, all of our EDs see about 850,000 annual visits, all of them put together. And, probably no surprise to a lot of you people on this call, you probably practice in similar settings, where about a third of these patients all over are over the age of 65. And so that was one of the big factors that really pushed our organization a few years ago to approach this on a system level. While the spread of the patient acuity and the age and the type of services offered by our different hospitals are different, because we do stretch. You can go to the next slide. We are located all over. You can go to the next slide. Yep, perfect. Thank you. Located all over Long Island, but we're also stretching into the city and upstate, and now we will be expanding even beyond that. Obviously, very different patient demographics. In some sites, like the site that I'm at now, I think our older adult population is closer to 40%. But still, overall, we are seeing a large number of older adults. So it is extremely important that we align our care to match their needs. So the system approach that we went through was, again, a few years ago, we underwent a system level accreditation where every single emergency department got the level 3 accreditation, which was the bronze accreditation that, Kevin introduced and Christina went into a little bit more detail about. And then a few years after that, we really focused on one of our community sites. It is our second smallest site, Glen Cove, which was actually recently honored by this group at ASAP for winning the Geriatric Patient Experience Award. So thank you for that. And that site really decided to take this to the next level, decided to level up, and we decided, that we were best suited at that site to go to the next level because the location of the site, the kind of patients that we were seeing, and the different healthcare facilities, the SNFs and the assisted living facilities that were surrounding that hospital. So that site became then, we completely skipped over level 2 and went straight for level 1. And it became the first community site in New York State to get a level 1 accreditation. And since then, there has been another site that's a level 1 accreditation. The rest of our EDs as of right now are level 3, but there are multiple EDs, and I'm gonna talk about some that are moving towards a level 2 as well. And if you see the math, yes, it doesn't compute to the previous slide. Previously I said 18, because one of our EDs is a children's ED, so that's not a geriatric ED. You can go to the next slide. So this was a publication that we put through with this group a few years ago. It's really focused on what we found in Glen Cove, but it is applicable really to all of our 17 EDs. So what we found over here, this is from our dashboard, that we have a What Matters Most dashboard that really looks at patients that are 65 and older that are admitted to the hospital. And then we look at how many of those patients have had a goals of care conversation and where did that occur? Did that occur in the emergency department or did that occur inpatient? Now, a little caveat with that. The where question is answered based on physically where the patient is. So again, for all of us working in the ED, we know a lot of times, unfortunately, we have patients in the ED, even though they're not active ED patients because they're waiting for a bed, but they're still physically in the ED. So for the purpose of this dashboard, we attributed those patients to the ED because it's still physically boarding and waiting in the emergency department. And what we found is, if you see in that first graph, is that patients that had, and again, this is just at that one small site, but when we sort that dashboard to look at all sites, it holds true. And we found is patients, if they have a goals of care conversation early on in their stay, so in the emergency department, they have a shorter median length of stay, inpatient length of stay, compared to if they had it as on the inpatient side. And it's pretty significant. Similarly, moving over to the second graph, we can look at the readmission rate. anyone who's involved in the hospital administration level, we know we really care about our readmission rate. It directly correlates with our CMS star rating, something that everyone's keen on improving, and any kind of strategy that we can employ that can ensure that our readmissions are curtailed is a win at the hospital level. And we can see again, patients that had the first goals of care conversation in the ED had a lower readmission rate than those that had it on the inpatient side. You can go to the next slide. So this was from our smaller site, Glencoe. Now we fast forward and move these initiatives over to our larger site. So this represents what's going on at our one quaternary care ED, North Shore University Hospital. So these are also snapshots again from that same What Matters Most dashboard. And you can see back in 2022, prior to the initiation of these initiatives, this is looking at in the pie chart again, all patients 65 and older that are admitted to the hospital. And you can see that 12% of these patients had their initial goals of care conversation in the emergency department compared to 88% who had it initially on the inpatient side. Even that's actually giving the emergency department at that point a little bit more credit, because if you look at the bar graph underneath, at that time, majority of these conversations were really happening in hour 10 plus. And I know we all face boarding. I know we face a lot of patients waiting in the ED even before they're admitted for a while, like the 6-hour turnaround time that Kevin described for his CAT scan. We're all very well versed with that. But despite that, most of our patients are not ED patients by hour 10. So really this was happening in the inpatient team while the patients are boarding. So that's when we decided, we need to make some changes. We really need to start focusing on, again, like what Christina and Kevin described, not only the code status, but really talking about all things that encompass this broad umbrella of what matters most. So moving over to 23, you can see we started making some headway, and I'm going to talk a little bit about how we did this and what this consists of, but just to show kind of where we ended up and, from where we started. 23, we started making some movement where you can see by the end of the year, we moved from 12% of these conversations happening in the ED to 36%. And again, if you go down to the bar graph, you can start to see that's hours since the 1 through 10 is hours since presentation to the ED. You can see 17% of the time, these conversations are happening in the first hour of the patient coming in. So, we like to talk about it like the golden hour of treatment. Everyone who works in the ED is very well versed with that. We know patients come in the first hour. You want to provide, excellent care, be it trauma, be it, you have patients with a stroke. Similarly, we really want to address what matters most as much as possible in the first hour of the patient coming in, because like, again, Kevin described, that would help establish where you're going from there. It may even end up saving a lot of time when you have the patient's agenda laid out right when you're meeting the patient. And then fast forward over to 2024, you can see the needle has moved even more. Now 44% of these conversations are happening initially in the ED. And again, you can see that blip, 17%, 15% happening in that first hour of the patient presenting in the ED. You can go to the next slide. And so what does this entail and who's performing these conversations? So I like to call this our goals of care dream team. It really took a while to build this, and it's not in any order of, a lot of these things happened simultaneously, but I'm going to describe kind of each spoke of this star. So of course the one group that's always there ubiquitously in any ED is the ED providers and the ED nurses, right? The ED team. So of course the ED team needs to be focused on the why as to what we need to do this, and then have the training to have an appropriate goals of care conversation. Again, like Christina described, beyond just the code status. Of course, the code status is important, and in certain patients coming in respiratory distress, of course you want to establish that. But with the patient coming in with the left lower quadrant pain, focusing on what matters most is not the code status, right? At that time, what you want to focus on is what is the patient looking for from that ED visit. And so, and I'm going to share some slides after this about how we really disseminated that why with the ED faculty, residents, and ACPs in nursing, and how we train them to help have these conversations. And I think really what is starting to get everyone on board is the why for the ED frontline team is going to be, of course, different from the why for the C-suite. And you know, if you can show that, hey, this is going to save you time, and this is going to save you energy, and this is going to help you because we're going to provide you with resources to make this happen, it just makes the process that much easier. Social work, not much more to say about that. We all love our social workers. They have, you know, a heart of gold. They are there to help with anything and everything. We're fortunate at a larger site to have social work presence from 8 a.m. to 11 p.m. And so they help with logistics, like sending the referral through the computer system to hospice if we want to send patients straight to hospice from the ED, and have these conversations with the family as well. So social work is there. Additionally, we employ our research interns. Again, I'm going to share a slide that shows how we presented actually some of this data that showed the decreased length of stay for patients having early goals of care conversations, as well as an increased contribution margin, which is basically a decrease in healthcare cost savings, having these conversations early. And we're working on publishing this data, and we presented an abstract on this at New York ACEP. And so we were able to get our research team engaged in this. So they are proactively screening patients in the ED that would be appropriate to have a goals of care conversation, and then connecting with the team. Seeing all of these efforts that we're putting together at our site, at a system level, the Hospice Care Network, which is one of our hospice facilities that's affiliated with Northwell, they partnered with us, and they provided us in the summer with a nurse who was able to come to our site a couple of hours a day to again, connect with the ED providers, provide education, and be available as an in-person resource to help with this ED to hospice transition. Actually, later on this week, we're going to be presenting a story of a patient that was transferred to us with an older patient with intracranial hemorrhage that neurosurgery deemed was non-operable, and we were able, and she was intubated at the sending facility. With the help of the hospice care nurse, as well as the rest of the team that you see over here, we were able to compassionately extubate that patient in the ED itself and send her over to our inpatient hospice facility. And up until this day, her family members are extremely appreciative of the care that they receive, you know, in the middle of a busy ED. And again, just for reference, this is happening at our quaternary care ED, which is, you know, a level 1 trauma site that's receiving all transfers from all different sites. So even in a busy ED like that, we were able to make it happen. And finally, the last bit, arguably initially the hardest bit to kind of get through, but I'm very excited to say that we were able to achieve this, was C-suite buy-in to make this happen. I think I saw a question pop up in the chat about who's having these conversations. So as I mentioned, yes, the ED team is starting these conversations, and the research interns are screening and connecting with us to have these conversations. But sometimes you just need someone else to go to the next step and really, you know, focus in on having a more in-depth conversation that, frankly, we may not be able to have the bandwidth to, because we're getting 4 or 5 patients an hour. So what we were able to do is, and I think not the next slide, but you'll see in a couple of the slides, we were able to show with the decreased length of stay and the increase in contribution margin with patients that had the early goals of care conversation, we partnered with our financial manager over at the hospital to put together a business proposal with a C-suite to show that if we invest in having a palliative care physician available to us in the emergency department to assist with these conversations, in the long run, this is actually going to be a healthcare cost savings, as well as, of course, a throughput initiative, because we're decreasing the length of stay. And that was approved. And I think 2 weeks ago, we were able to get this very important part of the STAR join our team, which is our palliative care physician. If you go to the next slide, it's just a brief overview, and I'm not going to read through all of this, about some of the education that we shared with our ED providers about the what, who, why, and hows of ED goals of care. We're fortunate also that we have one ED physician who's also a palliative trained, as well as a fellow who's an ED physician who's now doing a palliative fellowship. So we do have a lot of overlap, which is really wonderful. And we were able to share again, what is a goals of care? Again, as was mentioned before, it's beyond just advanced care planning. It's really talking about what matters most to them today. You want to go home today to be at your granddaughter's wedding. Okay, that is your goal. So really eliciting that. And then who should you have this conversation with? So we came up with an inclusion criteria that not only is the ED team exposed to, but also the research interns are screening for that. And then the why, right? In terms of the C-suite buy-in, the why was the increase in contribution margin and decreased length of stay. You mentioned those things to the ED providers. That's not what's going to get them excited to have the goals of care conversation. You really have to connect with what it is, what's in it for them. This is aligning with what the patients want, what the caregivers want. This is aligning with you saving time, so you're not spending an hour trying to get an ultrasound guided line on a patient who's a difficult stick, only to discover that they didn't want any IV access in the first place. And then finally, how, and I'm going to talk about that. So we can do all of this, but any kind of quality metric or any metric, if you can't measure and track and trend, it's going to be really hard to implement. So how do we do this? So that on the next slide, so we still use all scripts. That is changing next year. You can just click through. I'm sorry, I don't know why it's animated. I tried to delete it. Yep, thank you. Next year we are moving to Epic, so I'm curious to see how that's going to look like. But currently in all script, this is what we have. So we do have a separate goals of care node, but as ED providers, we like to have everything under one roof. So a few years ago, we embedded that node in our ED provider node itself. It's present, as you can see on the left-hand side, right under the HPI. And you just have to modify your template once, anybody from our sites who's on, and this is going to show up over there. And so it's kind of ingrained where as you're going through your HPI, before you go through your past medical history, the next thing that shows up right away is goals of care. And it kind of prompts you to document that. And if it's documented in this way, you can go to the next slide. We have a functionality in Sunrise to search for it. And then you can, when the patient comes in, we can just press one button and search for all goals of care notes that are done on this patient in the past, not just in the ED, but inpatient as well. And it can quickly give you an idea of what baseline are you working on. On the next slide just shows just one quick slide about part of a lecture and the training that one of our EM palliative trained providers gave to our ED team during the faculty meeting, a 5-minute MOLST. Most ED providers get intimidated when they see a MOLST because it looks like a lot of words and we don't like that. So she just gave a quick talk about it. You can do this in 5 minutes. If you can do it in 5 minutes as an ED doc, sign me up. And finally, the last slide is a table from the presentation that we gave at New York ASAP that just shows the first table looks at patients that had goals of care conversations in the ED versus inpatient. The second table looks at patients that had palliative care consultation in the ED versus inpatient. And again, this shows that patients that had these early goals of care conversations had shorter EDAC days, shorter ICU days, shorter total length of stay, as well as an increased contribution margin. And again, working on publishing this, but this was really the impetus that convinced the C-suite to invest in having a palliative care physician join our team. So thank you, and I'll answer everyone's questions in the chat.
Wow. Well, we're going to go to questions here in just a second, but just I put up some applause. I should put up some more. It's fantastic. Yeah, it's exactly what we hope. Being geriatric emergency medicine didn't make this possible for you all. Becoming geriatric accredited didn't make it possible. But to me, it's a quintessential example of you hope that as you start to develop programs that focus on the cares of older adults in your emergency department, you begin to find areas that really resonate for your patients in your hospital, and you go deep in those, and they can become transformative. And I mean, that's what we're talking about here. For starters, you just presented data on 8,000 or 7,900 goals of care conversations happening in the ER. That's fantastic. That's taking root that deeply. I think it's what's becoming an age-friendly emergency department is all about. So congratulations and thank you. One other comment, and then we'll turn it over to questions. I was just at the National Academies, and part of the conversation was actually with Mary Tonetti, was about goals of care conversations in the ER for, in this case, it was for patients with head trauma that were coming to the ER, but regardless, for older adults. And one person made the comment, do we really have time to do this? And I think your whole presentation at least aligns with my opinion, which is we don't have time to not do this. We can't afford to not do this. And I don't just mean 4 days later. I mean, yes, because if you don't stay 4 days later in the hospital, then you're not in the ER waiting to board for that bed. So actually shorter length of stay has everything to do with boarding in our ER. But I also mean for that patient right in front of me. You know, one of the ways that I manage all the complexity of the ER is I try and figure out what comfortable mental algorithm you fit into, and I put you into that, and I start doing tests on you for that. But if I do that before figuring out what matters to you, I can get you on the wrong pathway. And I can do all kinds of stuff that takes tons of time, whether it's the ultrasound guided central line you were talking about, or the CAT scan, or an admission that you don't need. I would argue strongly that we don't have time to not do this. The state of our ER doesn't mean we can't afford to do it. It means we have to do it in order to make sure that the care we deliver is aligned with the care our patients want and need. Aaron, I haven't had as much. I want to make sure, what do we see coming across as far as questions that haven't been covered in Dr. Sood's talk here?
There've been quite a few excellent questions. One of the things Dr. Sood is answering them as we speak. With the with this measure being in the ED, are you able to see where, like when at Northwell, when a primary care physician, do you get that information as well? And what you document, does that contribute to the overall picture of this patient's goals of care?
So as of right now, in our computer system, the primary care physicians are documenting in a slightly different area. We can access it, but it doesn't get attributed and pulled in the same place. But if the patient's admitted, the inpatient team's documenting basically in the same place and it gets added to it. That's how we were able to pull those graphs that show how many were done inpatient versus in the ED.
A follow-up question along those lines. I've known in other ones, like when we look at depression, we might be the PH, but for older adults, you might automatically get the geriatric depression scale. So are you doing these goals of care for all patients or just 65? How is Northwell approaching this? I mean, yeah.
Right. I mean, the focus is 65 and older, but of course, if it's relevant, we would do it in a patient that's younger as well, especially at the site that we're at, where we're receiving a lot of traumas, patients with multi-organ transplants. It's a very high acuity population. For instance, our admission rate is close to 40%. So it's a very high acuity population. So certainly sometimes goals of care discussions are relevant even in patients under 65. That there is a way to track those as well, but just in terms of keeping our scope limited to focus on this specific initiative, we're looking at patients 65 and older. And in terms of what prompts that conversation, and I think I included in one of the slides, we do have a list of some broad inclusion criteria in terms of the different diagnoses, like the things that we would think about, cancer, end-stage renal disease, dementia, the STAR diagnoses, patients with recent multiple hospitalizations. So we try to keep it broad. But again, I'm going back to the story that Kevin mentioned because that really resonates with me so much. Goals of care conversation could just even include something about what matters most to the patient today. They don't necessarily have to have, a life-threatening condition at that moment.
Kevin, I'll continue with some of the questions that are in the chat here. Scott Dresden was asking, I'm not sure if this, Dr. Shenvi, if this you might have this information. Are the resources which describe the funding implications for the CMS measures, are those available? What has CMS discussed about potential funding? Because right now it's attestation, but could you go into a little bit more elaboration of what CMS has begun to share?
Yes, and happy to have Kevin chime in here too. My understanding is that In 2025, it will just be an attestation, but it will be then posted on the CMS websites to show which hospitals are compliant. And then I believe, Kevin, correct me if I'm wrong, it's 2026, it will be rolled into the IPPS, the Inpatient Prospective Payment System.
I've
And
heard
happy to have
27, but
27, okay.
um,
So
yeah,
there's
sorry.
some pressure to do it because it will be publicly reported whether hospitals are compliant with it. And then, thank you, 2027 rolled into the IPPS.
Yeah, so just to add to that a little bit, because if you're anything like me, you've never heard the acronym IPPS and don't ever want to hear it again. I mean, basically, um, uh, it's an attestation measure. So Michelle Schreiber, the director of quality at CMS, Dr. Michelle Schreiber, who really, I just wanted, like, if I could stamp and Stein and applaud for her right now, I would. Who really, she probably isn't allowed to champion things as a director of CMS, but she kind of did anyways, to help get this through. Set it up initially as an attestation measure. So you just have to go through 10 domains and say yes or no, you do them or not. I know there's 5 domains, but there's 10 things in there, like 10 things that we do, one of which is this goals of care conversations that we're talking about. And the hospitals all want to say yes, presumably because it's publicly reported. And so you don't want to look like the hospital. It's like, nope, we don't like old folks. So they say yes. I mean, they want to be able to say yes to all of them. And then in 2027, it's mandated to be attested to either yes or no. You could say no, but you have to respond. And if you don't, you stand to lose up to 2% of your total Medicare funding. No one will lose 2% of their Medicare funding. 2% of Northwell's Medicare funding is like, I don't know, enough to buy a square block in Manhattan. Like it's a huge amount of funding when you look at it. So they're all going to make sure that they attest, and then they're going to want to say yes to it. There's already conversations going on in the background about could this become conditions of COP, conditions of participation. As soon as you enter a government room, you just have to start talking in acronyms. But condition COP, which would then mean if you don't do it, then you don't participate in Medicare at all. That's not yet the case. So bottom line, your hospital needs to figure out a way to start attesting yes to these things. And probably the pressure on it will increase over time. Although, of course, these things can change depending on who's running a CMS at any given time. I see a couple other questions in there from Renee. This measure is just in the States. Obviously, the topic probably is international, unless we've mastered immortality somewhere else. But the topic probably is international, but the measure, the payment measure, is just in the United States. And, you know, I'm going to comment on one more, and then I'm going to turn back to Dr. Sue to talk about when the palliative care physician is brought in a little bit more, because that question seems to be coming back up. But one more, is it a goal to have all 100% screened for goals of care? I think Dr. Sue alluded to it too, and I'll say from my own standpoint, not really. I mean, like if we did every screening test on every single patient that came to us, they'd never want to come back. Like, I mean, like, yeah, I mean, I think there's still a role for like, you're 66 years old, you were playing tennis, you sprained your ankle, you need to make sure we get an x-ray and send you home. Is this, so I don't think that my personal goal is not that every patient that comes through the door that has Medicare gets all of these questions asked, because I just don't think that would make sense. But certainly more than we tend to do baseline. Dr. Suda, what about this question that's, who does the palliative care doctor see? I know it was only 2 weeks ago. So by the way, before you answer that, she did all this stuff in her ERs without palliative care doctors. So like if you're thinking, oh, as soon as we get a palliative care doctor, we'll start having goals of care conversation. Nope. We're providers. We should be doing that. But now that you have a palliative care doctor, who do they talk to?
Sure. So as you mentioned, it's still pretty brand new. So we're still kind of working on and tweaking the inclusion criteria and whatnot. And I think I answered the question about it. You know, who is the palliative doc seeing? Is it every single person or only someone with an acute or chronic life-threatening illness? And it is the latter. A general goals of care conversation, you know, any of us should be able to have, as well as, one in a situation where the patient's acutely or chronically ill, but it really is for the more intensive, complicated conversations where we try to get the palliative care physician involved. And again, because this is still a very new initiative, we're trying to get her involved as much as possible in as many conversations as we can. I don't have any data to share from that yet, again, because this is so brand new. So, very excited to see where we end up with that.
Maybe you could expand upon that a little bit more. I know from my experience, we need obviously the provider in the emergency department, as Don just said, that that's a core competency and that is responsibility, especially for those emergent conversations. But when you have someone that is much higher on the ESI and you're discharging them home, but they have a chronic condition, have you thought about potentially connecting with like outpatient referrals to outpatient palliative care? Have you discussed that or, started to take tentative steps in thinking about that?
That's a great question. We haven't yet started connecting to outpatient palliative care, but that is certainly a possibility. And I think after this call, I'm going to talk to our palliative care physician about that. But that being said, just having their availabilities has been able to expand our inclusion. For instance, just the other day, we had a patient who was a patient came in with a newly diagnosed leukemia a month ago, was getting treatment, sent in by the oncologist to be admitted for fever on chemo. Seems like a very easy enough thing, something that we can handle in a matter of minutes and move on. But because we had the palliative care physician, we got her involved and she spent time with the patient and the family. And despite the fact that, of course, they were still adjusting to the new diagnosis and getting all the treatment that was offered to them, they were extremely appreciative of having someone able to sit down with them, talk about what matters most, fill out a mold. And as it turns out, even though they wanted everything done in terms of getting all the chemo, they did sign do not resuscitate, do not intubate. And they were thinking along those lines for the future, understanding the gravity of the diagnosis. Without the availability of the palliative care physician, we may not have had that conversation at that time.
Excellent, excellent. I know we have just a few moments left. Before I hand it off to Kevin for final farewells, I just want to say, as the director of the Geriatric Emergency Department, as our name implies, we are a collaborative, and so as a nation, we are going to be all learning this same stuff together. And just as Dr. Sood's wonderful example on this this first domain, we want to be able to share and disseminate this. So in the coming year, we'll be able to cover all 5 of the domains. And if you have a great example of something you're very proud of that is meeting these, and we would love to be able to share that with our audience, because we can go farther faster. This is better working together. So we do have on our website right now, we do have a landing page for some materials. This is going to grow as we learn more. We have better examples. So please come to our website, become a member. All our resources are free. We have free resources from toolkits to webinars and with credits. So please join us, and we're also able to provide additional services as well. So thank you very much, Dr. Sood, for showing this and being able to share your knowledge and your experience in this very important aspect. So with that, I'm going to hand it off for Kevin for final comments.
Oh, thank you. Again, thank you to everybody who's here, and especially Dr. Shenvi and Sood and Aaron for amazing work. I think back to when I was a resident and we had big debates about whether you should ever test anyone for HIV in the emergency department. That was a public health thing. We don't do public health things. We do emergencies in the ER. Well, I don't think we'd have the same debate today. I think it's obvious that we need to be testing for things. And I don't think it's too long ago, and maybe still the case, that lots of us say, gosh, goals of care, that should all be figured out before you show up. Yeah, it should be. And when I live in that world, I'll let you know. But in the meantime, we all have to do the best in the departments we're working in. And I'm personally incredibly grateful for this sort of culture change and evolution that this demonstrates in meeting our patients where they're at, making sure we understand what their needs are, and tailoring our care to their needs, as always should be done. So this is fantastic. Really appreciate it. Please tune into the GEDC for other webinars and more materials, and also go to the website. There's so much good stuff on the website. It's a new website. I think it works. If it doesn't, it'll work real soon. But there's lots of great materials to help you meet this new hospital measure. Again, thanks to our panelists, and let the GEDC know how we can help. And anything I forgot to say, thank you to Johnny Hartford and West Health. Without you all, we wouldn't be existing to make this all happen together. Have a great Monday.